So my name is Simone Nardin. I'm from Italy. I'm an intern in the University of Genoa, so in the north of Italy. And now I'm currently working with Professor Alessandra Gennari in Novara, that is a city close by Milan. Yes, the study was based on what we usually see during our clinical practice, that is related to the patient undergoing adjuvant endocrine treatment for patient premenopausal for luminal early breast cancer. So the patient that usually at moderate high risk of relapse that are administered with GnRH analog plus tamoxifen or aromatase inhibitor. Usually we saw that during our clinical practice, sometimes the patient we are visiting are not adequately suppressed related to the ovarian function, but we don't know which factor could be related to this problem and which impact on the outcome of this patient could be administering an aromatase inhibitor when the ovarian function is still ongoing. So we try to perform an exploratory analysis of two observational prospective study in order to assess if we can somehow predict which patients are more likely not to be suppressed during the administration of GnRH analog, and if this suboptimal ovarian suppression could impact the long-term outcome. So related to the baseline characteristic of the patient, only the use of aromatase inhibitor is related with a higher risk of suboptimal ovarian suppression. And in our cohort, we saw that this problem is not related only after the first year of treatment, when we have about 8% of the patient with a suboptimal ovarian suppression. But going throughout the year of treatment, so at 5 years of treatment, that usually is the standard of care, this percent goes up to 20%. So 1 out of 5 patients treated with GnRH analog plus aromatase inhibitor is not adequately suppressed for the ovarian function. This could be a problem because we saw that usually the standard for the patient is to be suppressed and have a lower level of estrogen detected by lab test. In this patient, the estradiol level are above the limits, and this could impact the outcome. Fortunately, in our cohort, none of the patients with a suboptimal ovarian suppression has relapsed. But we have a short follow-up. We have only about 4 years of follow-up that for those patients probably is not enough to assess the long-term outcome. So we need probably a longer follow-up to see if the administration of those aromatase inhibitor in those patients that are not adequately suppressed could have an impact on the relapse or on the long-term survival of the patient. For the clinical aspect, we can assess the suboptimal suppression if the patient restarts the menstruation usually at least 3 months after the start of the GnRH analog. The other evaluation that we usually perform is the lab test of the estradiol, so the E2, and the FSH level in the blood. The problem that we saw comparing the literature, it usually when we had the literature reports, for example, there is a 1-year evaluation of the SABCS study, they use, or also other more recent study, mass spectrometry evaluation that can detect a really low level of circulating estrogen, up to 0.01 nanogram liter of circulating estradiol. In our institution, but also I saw that also other colleagues, and last November ASCO posted a survey about this topic. Most of the lab perform with immunoassay, so we have a really higher level of detection. So for example, in our institution, the limit is 15 of nanogram liter of estrogen. Below this limit is not detectable. How much is lower? So we usually in our study, we use a cutoff for 25.1 nanogram liter of circulating estradiol to assess if the patient is suppressed or not. But it's not easy to compare because all the other trial reporting this assessment use another type of evaluation that is different of that we usually use in our clinical practice. Not only us, but also the other center from Italy, or probably also from other countries, is the recent survey from ASCO. In our study was a mean of let's say 39 years old for the patient. So we can use sometime the age to better assess the premenopausal, postmenopausal status, but it's also easy because we saw that nowadays we can have patients also 50 years old that are still in premenopausal status. So this could be something can help us to test maybe more frequently the patient, but the only way to be sure that the patient is in premenopausal or postmenopausal status is the lab test of the estradiol, the FSH level at least. Maybe also the anti-Mullerian hormone and the progesterone, the LH, could help us to better assess the status, but at least the estradiol and FSH level are mandatory to discriminate this new population. In our study, we had 343 patients enrolled only in our center. So even if the two studies we performed the exploratory analysis are multi-center, for this type of exploratory analysis, we use only the patient enrolled in the main center. We didn't saw any association with other type of clinical characteristics. So also we could expect that maybe lower age, a higher BMI that is described in the literature that could reduce the efficacy of GnRH analog on the suppression could be related in our study, not only for the baseline characteristic, but also in the univariate and multivariate analysis. The only factor that remain associated with this higher risk of suboptimal suppression is the administration for the aromatase inhibitor. We could change a bit our perspective, because usually in our clinical practice we were used to assess the estradiol level after 1, 3, and 6 months starting the GnRH analog and stop. Also the international guideline, someone recommend the dosage of estradiol, but without a time point how to evaluate that. For what is our point of view, probably it could be useful to assess it at least once per year. That is usually when we saw patient. This depends on the institution, but usually every 6 months or once per year, we saw the patient during the follow-up, and we perform lab tests, for example, to assess kidney function, liver function. So probably in this type of consultation, it could be useful to assess also the FSH level and the estradiol level to follow the patient throughout all the period of the treatment with the GnRH analog. So this could be something that we could implement in our clinical practice. I think that this morning we saw something that really interesting for the patient, because usually when we talk nowadays, we are starting to talk about the de-escalation treatment. And this morning, Professor Lambertini reported the first interim analysis of the Europa trial for the de-escalation of the adjuvant treatment in elderly patients, so patients more than 70 years old, that are luminal-like patient, early breast cancer, stage 1, could be administered only with adjuvant radiation therapy or only adjuvant endocrine treatment. This is something that we need to address, because we know that the adherence to the endocrine treatment is not so simple, because every day we saw patients that have side effect for the aromatase inhibitor that we usually use for the postmenopausal patient. And you reported a really improvement in the quality of life of the patient that underwent only the radiation therapy. So a short period of treatment without great side effect, and improve really their quality of life. We still need longer follow-up to assess also the efficacy of omitting the endocrine treatment in this type of patient. But of course, the first data are really reassuring. And similar to this topic, also in this general session, performed also the analysis of the omitting the axillary dissection in the patient with stage 1 and stage 2. Of course, the in-sema trial enrolled all the patient up to 5 centimeters, but we saw that the patient with T2 tumor were only about 10%. So for the patient with T1, stage 1 disease, we could avoid the axillary dissection. That could be a really problem impacting the quality of life for the lymphedema and on the long-term sequelae that could decrease the quality of life for the patient. And this study really reassured us to not perform the axillary dissection when the patient didn't have not suspect node positivity to the imaging, so the ultrasound usually is the standard of care to assess that. And even if the patient had a positive sentinel lymph node biopsy, we could avoid the dissection with a superimposable outcome of the patient. So this is something that we could easily implement in our clinical practice to avoid the sequelae in our patients. So I see that for many years we try to implement the treatment, the outcome with better treatment, stronger treatment to also give the patient the best of the therapy. But nowadays we see a shift of the paradigm, because probably many patients that we treat with novel drugs don't require this type of treatment. So all the trial of the de-escalation also related to the genetic signatures that could help us to better treat the patient, not only with the best treatment, but best treatment for them. Also de-escalating the treatment when it's not necessary to perform all the type of treatment that we usually do. We saw recently the Fergain trial, that is something that we really help us to think of this type, so we can manage the treatment throughout the neoadjuvant or adjuvant treatment to better select the patient that need a stronger treatment, of course, but even those that don't require so massive treatment. Also all the data we are trying to see for the anthracycline-free treatment for the luminal cancer or the HER2 positive now, for example, in our institution, usually perform a neoadjuvant treatment for HER2 positive patient without anthracycline. That could affect could have a cardiotoxicity, a long-term cardiotoxicities that could impact long-term outcome of the patient. So trying to avoid those over-treatment that I call over-treatment, but it's not correct, because we know that those treatments are really effective. But probably not in all the patient we need to administrate all those drugs that we are studying now.